When you're dealing with lung scarring, there's one huge question that can change absolutely everything. When do we start the fight? So today, we're diving into the critical timing of antifibrotic therapy, where getting it right can make a world of difference. You know, for doctors and their patients who are staring down a diagnosis like pulmonary fibrosis, this is so much more than just writing a prescription. It's about setting a course for the future. Getting the timing right is, well, it's everything.
And as you're about to see, the answer is not a simple one-size-fits-all kind of deal.
No.
The right strategy really comes down to the specific type of lung disease we're looking at. So, let's break down the 3 key scenarios.
Okay, first up, a quick refresher. Antifibrotic drugs, we're talking about nintedanib and Pirfenidone here, they aren't a cure. Think of them more like hitting the brakes on the scarring process. And the way we measure that is with something called forced vital capacity, or FVC. It's basically a test of how much air you can forcefully push out of your lungs. So our main goal here is to slow down how quickly that lung capacity fades.
So, let's start with the most straightforward case of them all, idiopathic pulmonary fibrosis, or IPF. In this situation, the decision is a total green light.
Yeah, IPF is pretty much the poster child for these drugs. It's the classic reason they were developed in the first place. We have tons of solid evidence from multiple trials showing they really do slow this disease down. And the diagnosis gets locked in when a high-res CT scan shows this very specific scarring pattern called a UIP pattern. You can think of it like the disease's unique fingerprint.
And this is the absolute key takeaway. For IPF, there's no waiting around. There's no debate. The second a definitive diagnosis of idiopathic pulmonary fibrosis is on the table, the guidelines are crystal clear. It is time to start treatment, period.
All right, let's shift gears to our next category. This one covers all the other types of lung fibrosis that aren't IPF. Now here, the strategy isn't an immediate go. It's more of a watchful waiting approach. We call this progressive pulmonary fibrosis, or PPF.
So, what does progression actually mean? Well, the guidelines are super specific. A patient's disease is officially considered to be progressing if they hit at least 2 of these 3 markers within 1 year. So, number 1, are their symptoms getting worse? Number 2, are their lung function tests dropping in a meaningful way? And 3, does a new CT scan show that the scarring has physically spread?
And that's it right there, meeting that threshold, 2 out of those 3 signs. That is the specific, evidence-based trigger. It's the moment the disease shows its cards and proves it's on the move, and that's our cue to jump in with antifibrotic therapy.
Now, it's also important to know what the options are here. Thanks to a huge study called the IN-BUILD trial, nintedanib is fully approved for PPF. Pirfenidone, on the other hand, even though it's a go-to for IPF, is still being evaluated for these other progressive diseases, so it's not quite a standard option just yet.
Okay, and that brings us to our third and final scenario. This one is a really unique and important special case. It's the lung fibrosis that's tied to an autoimmune condition called systemic sclerosis, or SSc-ILD. And here, the whole way of thinking shifts again, this time towards being much more proactive.
So based on what we just talked about with PPF, you might be thinking, okay, so do we just do the same thing? Do we use that same wait-and-see approach and look for 2 out of the 3 signs?
Well, the answer is a firm no. And this quote from the 2024 guideline tells you exactly why. The consensus among experts is that fibrosis in systemic sclerosis is inherently progressive. In other words, its nature is to get worse. We already know it's on a forward path, so waiting for it to prove it is a risk that's just not worth taking.
And this really shows the massive shift in strategy. For SCS-ILD, the recommendation is to think about starting therapy early, way before the patient would ever meet those strict criteria for PPF that we just discussed.
Now, this proactive approach isn't just a hunch. It's backed by really solid data, especially from a study called the Census trial. It showed nintedanib works really well for these patients. The guideline is pretty clear. If a CT scan shows that 10% or more of the lungs are already affected by fibrosis, that's enough to get the treatment conversation started.
All right, let's pull all of that together. We've talked about 3 different diseases and 3 different approaches. Here are those decision points, right next to each other.
This table is really the core of everything. Let's run through it one last time. For IPF, the trigger is the diagnosis itself. You always start treatment right away. For other types of interstitial lung disease, you start only if they prove that they're progressive. And finally, for systemic sclerosis ILD, you start early, as soon as you see a significant amount of fibrosis, because we assume it's going to progress.
And that leaves us with a really interesting question to think about for the future. I mean, this field is changing so fast. As new trials and new data come out, how are these triggers going to change? Could we one day see a proactive, early start approach become the standard for all types of pulmonary fibrosis? It's a huge question, and one that researchers are working on day and night. Thanks so much for joining us for this explainer.